All right, everyone. Hello, welcome. We're just opening up to allow everyone to come on in. We're just giving everyone a moment to also prepare the live streaming. Welcome. Thank you all for being here. We'll give everyone a couple of minutes to get connected. And like I said, we're just allowing a couple of moments for that live stream to kick in. Wonderful. Okay. Welcome, everyone. Thank you so much for joining us tonight. We are here to talk about IVF and endo and adeno and all of the concoction is what I think a lot of people feel or refer to it as when it comes to the factors addressing IVF or with endometriosis. My name is Jess Taylor. I'm the CEO of QENDO, and I'm here with Dr. Rusty from Adora Fertility. And I would just like to kick off by acknowledging the lands that we're all coming from today. I'm coming from the Quandamooka land out in the Redlands, and there's lots of beautiful islands around me. I just spent the weekend on Stradbroke Island, which was really beautiful to get back into nature. And acknowledge as well the people here with lived experience and the significant others that walk along this journey with them. And I would really like to pay my respects to any elders past, present, or emerging, but also the other leaders, many other tribes, people, organisations, and advocates who have spoken about the issues that we're going to be talking about here today, and they have done so for decades. And we are here and we're able to do this work because they spoke up, because they came in circles and in communities and discussed and shared and talked. And we continue to do that here today. I'd also like to note that there may be trigger discussions going on here this evening. You are here because you're interested in IVF and fertility, but it can bring up emotions. I think we can do all the most amazing therapy in the world, but at the end of the day, we are still human and we can still be triggered. If you are feeling emotions at all and you would like to talk with someone, please contact us. You can pop a message in the chat to Ashen or myself. And we can get you connected with our beautiful nurse, Jill, for a debrief call. That can either be today or please also contact us across the next couple of days. If you do want to chat, we are here. All right, we will kick into it. Well, how tonight's going to work is we're going to have a part one where Dr. Rusty is going to talk a bit through some of the fundamentals and some of the, I guess, back to basics. It's going to be really good to get some foundational information out. We're going to pause for some questions. So in the chat or in the Q&A, you will be able to pop in some questions there. If you can, while we're kind of kicking off, give the Q&A a bit of a go to just check in that you can make it start working. Again, if you do have tech issues, you can contact Ash and I by sending us a message or commenting in the chat in the Q&A, because we are monitoring that. I can see a couple of questions already starting to come through. So that's good. People have their admin sorted. Okay, Dr. Rusty, over to you, and then we'll pause for questions and then we'll kick off back into part two and get going. Over to you. Thanks for being here.
Thank you. Thanks, Jess. Thanks, Ash, for inviting me. Yes, thanks everyone for joining this webinar. Essentially what I would like to do is I would like to take you through my initial consultation. So when I see couples for initial IVF consultation, so I will take them through first. I discuss first big picture of their fertility. We just establish their building blocks of fertility to understand. So their fertility, then next step is discussion of IVF treatment if they need to have IVF treatment. So this is why this webinar consists of two parts. First is to understand what factors determine success in natural conception or IVF or any other fertility treatment. So then we try and understand how you can establish your individual or any couple's individual factors and their individual chance of having success in IVF, or what interventions, what optimizations we need to do to improve their chance. So this is first part. Then I will stop. Then we can do Q&A. If you have any questions about those factors, I can answer. So then we can move to the next step, which is a discussion and explanation of IVF process. So there are a number of 7 stages of IVF. I will take you through 7 stages of IVF. So like what happens in real IVF cycles. So then I can answer questions which is on IVF cycles. So yeah, so first part is factors which is affecting IVF cycle. So generally, when I see patients, of course, before seeing patients, I go through their clinical notes, try and get as much information as possible. Then, before actually seeing patient, in my mind, I establish the 2 major factors to understand their fertility and understand why why they're having infertility, why they didn't conceive naturally, and also estimate the odds of success in various fertility treatments, including an IVF treatment. So essentially, we create a map, like terrain of their current fertility. Then we create a plan for navigation. So you will see from the slides, each person's or each couple's fertility is unique. So each couple have their own advantages in their fertility, and they have their own disadvantages. So generally, you create strategy once you understand what's their advantages and disadvantages. Together with a couple, you create strategy where you utilize their advantages to compensate for their disadvantages to achieve successful pregnancy. And you try to find the shortest route possible. Once you map out your fertility or patient's fertility, so together, once we map out, and we know where we may come across obstacles, how we can navigate. Some obstacles we have to actually conquer, we need to treat before we can achieve success, and other obstacles we can go around depending on other remaining factors. So essentially, there are 2 big factors determine any couple's fertility in big picture. There's a lot of small factors, but we're looking at the big picture at this stage. Then we can go into detail. So this is called embryo factors and uterus factors. So they're independent factors and they can compensate for each other. So the uterus factors are determined by egg general and big picture, egg quantity and quality, and sperm quantity and quality. So of course, there are other factors like medical history, lifestyle factors. There are a lot of small factors, but in big picture, egg quantity and quality, sperm quantity and quality, by and large, determines how easily they can create high-grade blastocyst embryos. Let us say if they do not have any obstacle for natural conception, if these 4 factors are good, they can easily create high-grade blastocyst embryo in natural conception and keep these embryos keep landing in the uterus every month, every other month. Then one of those embryos implant. So the nature's limit for implantation is determined by these 4 factors. So this we can essentially establish for a quantity we establish by their current egg reserve, which is determined by AMH and not determined, assessed by AMH and follicle count. So looking at anyone's anti-AMH result and follicle count together, you can tell whether they have a high egg reserve, like in PCOS, average egg reserve, or low egg reserve, or critically low egg reserve. So that is one factor. And then second is the quality is determined by a number of factors, mainly due to age. So second is the overall health. And the third is, and then whether after we find out in some patients, we believe they have a good egg quality. Then after IVF cycles, if you find out if they have a poor egg quality, this usually depends on maturation of their eggs. That's the receptor problem. So that we address during IVF cycle. So by far, age and overall health determines egg quality. So so then we go through all the factors like medical problems, medications, lifestyle factors, smoking, all different factors, and we try and address those factors and try and optimize as much as possible. So when it comes to the sperm, again, the biggest two factor in the sperm level is sperm quantity and the quality. So that is assessed by semen analysis. If we have a good concentration of sperm, good morphology, that's quantity, and good motility, that's quality generally, so we can assume so sperm is optimal. If not, we try and understand why is that. There is an age factor, but not as much as in female fertility. So, and the medical history, we understand medical history and the profession, which is very important for sperm production in terms of, let us say, sedentary lifestyle, some professions which involves working with, computers for a long period of time, or long haul driving, or cycling in the long distance cycling. These are factors which can increase the temperature, structural temperature for a long period of time that can reduce sperm quality. So we try and understand and address. Of course, lifestyle factors very important, diet and smoking. So we try and address. But by just looking at sperm analysis, we can tell if the production is happening optimally and the overall quantity and quality of the sperm. So, and just briefly, I explain why age is important for egg quality. So, because let us say at the age of 30, for example, across 12 months of period, if women produce one egg at a time, so approximately 70-80% of these eggs are normal, which means within 12 months, maybe 10 months, women produce a healthy egg. So then let us say at the age of 40, this rate of healthy eggs reduce. Let us say during 12 months period, maybe 5 or 6 healthy eggs produced. Remaining months are wasted. So, but one wrong assumption generally we come across is when women's age is, let us say, older, 40, 42, some think that all eggs get affected. No. So the rate of abnormality increases, which means, let us say, if you produce healthy egg at the age of 41, that is, which means chromosomally normal, and that's as healthy as at the age of 32 or 30. So just a proportion of healthy eggs reduce. So that's very important, especially in IVF, which means attrition rate will be higher. So yeah, so that is in terms of age. So when you look at the embryo factors, generally, not in individual couples, but in general population, 80% of the success in creation of embryos determined by egg, 20% determined by sperm. So this is very important to understand for us, especially IVF specialists. So when we analyze the cycles, generally this is due to egg, unless sperm quality is poor, unless we see the poor development of embryos once sperm is got activated. So, but always we assume, let us say you have 10 eggs, 10 embryos, and let us say 8 didn't develop. We generally assume probably 2, 3 didn't develop because of sperm, remaining didn't develop due to egg, generally, unless we find a direct sign of sperm problem or direct sign of egg problem. So this is in big picture. Creation of embryos is a very important factor. And if you keep creating high-grade embryos easily, naturally, or in IVF, pretty much you have a good supply of healthy embryos. Even if you have some problems in the uterus, you can overcome. So now this is about embryo factors. So we actually in clinic, when I see patients, we try and together understand with a couple. So we understand what factors in their favor in embryo creation, a quantity, quality, sperm quantity, quality, lifestyle factors. We try and understand which factors need addressing and which factors in their favor. And we can actually estimate how easily we can create embryos, high-grade embryos in IVF. So this is a big factor of embryos. Then next factor is uterus factors. So here also it's important to know that essentially when we do IVF, we think even in naturally. So when implantations do not happen, and generally it's 80% due to embryos, 20% due to uterus. So embryo plays very important role in successful pregnancy. So here, if you look at this, for embryo creation, 80% egg plays important role. For implantation, 80% embryo plays a role, the 20% uterus. So this is the main things we need to always be aware of. This is a nature's design, and we can only understand and incorporate in our analysis. Okay, so the second factor is uterus factors. Essentially, uterus factors determined by two big group of factors. One is if there is inflammation, chronic inflammation in the uterus or surrounding tissue, which means if you have inflammation, there's a lot of immune reaction going on. Essentially, your immune system is fighting with inflammation, inflamed cells, and that's causing huge temperature increase, which embryos are very sensitive to temperature, and a lot of chemicals getting released. So inflammation, and whether there is structural problem in the uterus, which can reduce the chance of implantation. So here, biggest factor when it comes to inflammation is adenomyosis. So generally, the adenomyosis probably one single responsible factor which causes repeated implantation failure. So repeated implantation failure means transferring 3 or more high-grade embryos without successful pregnancy. So there's a lot of factors for that, but biggest culprit is adenomyosis. Second biggest one is endometriosis. So because adenomyosis, what adenomyosis does is it can cause erosion of the endometrial lining, and it can cause inflammation of uterus. But very importantly, you shouldn't get alarmed about it. Why? Because we know adenomyosis is common like endometriosis. We don't know exact statistics as yet, because we are now understanding more and more, because we are doing more deep pelvic scanning, more MRIs, and we are now understanding more about adenomyosis. We know millions of women have adenomyosis and have successful pregnancy without any fertility treatment. And we don't even know they have adenomyosis. Number one. Second is a lot of women have successful pregnancy with adenomyosis without doing any intervention. They just do IVF, then transfer embryo, and immediately get successful pregnancy. But small portion of women who with adenomyosis can have a repeated implantation failure. So if they have, then we need to have tools to treat. So generally, we need to use GnRH analog to stop the periods, reduce estradiol for a period of time, to let the uterus to heal and reset the uterus, and then do the transfer. When we do that, we have a very similar chance of pregnancy as patients who do not have adenomyosis. There is a treatment for that. And a lot of patients, like in our clinic, a lot of patients, maybe most patients with adenomyosis, get successful pregnancy without Zoladex, which is without GnRH analog, or with after that. So essentially, yes, one thing is if there is a pathology, we cannot ignore. We need to know, because we need to optimize the health. We cannot ignore, and we just need to include our analysis. Again, equally, it doesn't mean that patients need to should get worried about it. Second one is endometriosis. Mild endometriosis to implantation, but here we are talking mainly uterus. So mild endometriosis impact to implantation is not very significant, but severe endometriosis, stage 3, stage 4 endometriosis, can reduce the chance of implantation quite a bit. So these conditions do not prevent us from achieving success. Only the thing they do is they reduce the chance. So let us say if there is no issue with the creation of high-grade embryos, you can just do IVF and create 2 or 3 high-grade embryos, then you can accept that chance with adenomyosis may not be like 40% for your age, for example, maybe 30%. You still transfer, and if you get success, 1 in 3 chance of successful pregnancy, the problem is solved. If not, you can transfer next embryo. So if you get success, problem is solved. But usually we start addressing these issues if we have repeated failures or if you cannot easily create high-grade embryos. So this is about endometriosis adenomas. Hydrosalpinx is another condition. So where fallopian tubes get swollen, there's a fluid can come back into the uterus, which can wash away embryo or can be harmful, toxic to the embryo. Essentially, the hydrosalpinx also reduces chance by 50%. Let's say not 40% chance, 20% chance. Generally, hydrosalpinx easy to treat. We recommend to do laparoscopy and salpingectomy, remove the fallopian tube before doing the transfer. So then pelvic infection, which is not common, chronic pelvic infections can also cause for if the patient doesn't have a treatment, we need to offer treatment. So the next group of factors is having structural problems in the uterus, like fibroids, polyps, and septum in the middle of uterus, adhesions inside the uterus, fluid inside the uterine cavity, or lining being thin. These factors, again, they do not prevent us from achieving success, but it can reduce our chance of success, and we need to optimize uterus first. We need to treat those conditions first. If we need to treat, like fibroid, for example, if it's outside the uterus, small fibroids, we don't need to treat. If fibroid going into the uterus, we need to treat. So these factors we need to address. So if you look at the big picture, so all these problems, couples have various different problems, but once we understand their individual factors in big picture, embryo and uterus picture, then we create individualized plan and we try and find the shortest route for success, then optimize the treatment, then go through the treatment. Then when we do that, most couples get successful pregnancy in IVF. I will explain how. Let us say we see 100 couples. So when we do transfer, because the fertility is designed in such a way, is when human fertility, whether it's natural or IVF, so which is attempt based, so probabilistic. So let us say assume 100 couples, in average 30% they have a successful pregnancy. So let us say 100 couples do first cycle of IVF, transfer one embryo, then 30 out of 100 get pregnant, 70 left. So this is after one round of transfer. Then 70 couples do second transfer. Then in average, 30% get successful pregnancy. So maybe 30% of 70 is approximately 15 to 20. Let us say 20. 20 get pregnant, then you have 50 left. Then 50 couples do third round of IVF embryo transfer. Then 30% get successful pregnancy, let us say 10. So 40 left. So after like 3, 4, 5, 6 rounds of IVF, 80, 90% couples have successful pregnancy despite having some of these conditions. So, and our job is to understand each factor in each couple and to reduce the stress of IVF, do as little cycles as possible, and achieve success as quickly as possible, and reduce the attempt. But one thing is important in IVF is we should understand is essentially when natural conception is happening or IVF conception is happening, nature is still deselecting unhealthy eggs and sperm and embryos in all the stages. When you see beautiful healthy embryo, whether you do PGT testing or not, it doesn't matter. So when you see a healthy embryo, generally as we and patients, of course, we want to have a success, and we believe that works. So chance for that embryo, depending on the age, maybe 25 to 50%, for example. But if it doesn't implant, doesn't mean anything wrong with the couple's fertility. It's just nature still selecting healthy embryo, provided there isn't any major problem in the uterus, like hydrosalpinx and all these issues. So, and which means that then if we rule out all our problems, then with confidence you can go to the next cycle. So why it is with confidence? Because there's something called cycle independency in IVF, which means each cycle is independent of previous cycles or future cycles, which means each embryo has got its own chance. If you had 2, 3 failed embryo transfers, provided everything being equal, then for next embryo, it doesn't matter. It has got its own chance. For that embryo, that's first cycle. So if it's healthy embryo, it implants, you have a successful pregnancy. So this is why it is important to not get disheartened if you can't produce high grade embryo in one cycle, if you can't have implantation in another cycle, because each cycle you are having new cohort of eggs which are independent of previous cohort. Your partner is producing new cohort of sperm which is independent of previous cohort, and you have a new chance of creation of high grade embryos, especially if your cycle is optimized by changing the drugs trigger. Then if you create high grade embryo, previous cycle doesn't matter. Then same for implantation. So sometimes some comments we get is we are repeating same thing, expecting different results. Yeah, it's a kind of definition of madness. No, actually, we are not. Even if we are repeating same process, maybe even sometimes using same drugs, we are not repeating same thing. We are creating new embryo, and it's got its own chance. It has got its own ploidy, which means each cell in the embryo, like there's 140 cells, they're unique and they have got their own set of chromosomes and they have their own chance. So this is why we are not repeating same thing every cycle. We're creating new chance, new embryos. But of course, we cannot ignore if there are some certain pathologies which may be reducing chance for each embryo. That's repetitive. It's not independent. Let us say there is a fibroid going into the uterus, or there's an adenomyosis, which is so significant. We should take this into account, but we cannot ignore, because this is not new. This is a repeatable problem. So this is why we need to get full understanding. Each couple starting IVF, they should understand. Let us say for one couple, they may have very good egg quantity and quality, but poor partner has got poor sperm parameters. So here you can solve the problem by optimizing egg quantity and quality in IVF, and that will compensate for sperm. How does it compensate? I'll explain. Let us say if you produce 10 egg, out of this 10 egg, 8 is healthy in one cycle, but sperm with ICSI, let us say 6 sperm is abnormal. So you can produce 2 healthy, because remaining 2 sperm is normal. So there was too much, normal to normal match, and you can have 2 beautiful embryos. So, or if you produce like 12 healthy eggs, same proportion of sperm is abnormal, you may produce 3, 4 high-grade embryos. So there is a ways you can compensate for one problem with other. Same with implantation. If you have poor implantation, if you keep creating high-grade embryos after optimizing uterus, with each transfer, you have 30% or 25% chance. But once implantation happens, the problem is solved. So this is why it's important to understand your individual factors as a couple and understand where your strength is, where your weakness, and create the strategy to overcome the weakness by using your strength. Yeah. So then you can, which means that you take the shortest route to the success. So this is the end of my first part. We just understanding biggest factors in what determines success in IVF before we move actual discussion discussing IVF stages step by step.
Wonderful. Okay, well, you're making a lot of dots connect for me. So thank you very much, as someone who hasn't had to go through IVF, but so many people in this community and this team have and will and are. A couple of questions that have come through. So, for someone with stage 4 endometriosis, does having excision surgery increase the likelihood of conceiving naturally or with IVF?
Yes, very good question. Thanks, Jess. So, yes, actually, it does improve chance of conception both naturally and if they have to do IVF in with IVF, because as you know, like stage 4 endometriosis, this chronic inflammation which has been going on for many years to come to stage 4. What it does is, of course, as you know, it causes a generalized inflammation of the uterus. So and there's massive immune reaction is going on. The is essentially to remove the if you don't have a surgery, to remove that endometriotic cell, the immune system called macrophages need to come actually physically need to eat and take this through the lymphatic system in discard. So body does this all the time. We think in women with endometriosis, the immune system cannot catch up. By the time they clear those endometriotic cells, new period starts, a new discharge gets discharged. So then what happens is the whole area is a battlefield between immune cells of body. They're trying to help, and this endometriosis is not helping. So and it causes inflammation. So just physically removing excising is the best treatment, of course, and it will remove all the cells physically. So that will subside the inflammation. And of course, if in stage 4 endometriosis, there's a lot of adhesions, and once the removed adhesions are removed, especially the fallopian tubes are patent, then of course, so certainly chance of successful pregnancy increases, especially the first 6 months after the surgery. And similarly, so surgery improves chance of implantation if we do IVF. If they're not successful after the 6 months, if they do IVF, then it does improve chance of implantation.
Excellent. And just to confirm, that's for, or to state that's for endometriosis. Adenomyosis is a whole different ball game. And obviously, we're doing a laparoscopy with excision surgery for endometriosis. We can't do that for adenomyosis. Excellent. Thank you. There's another question here in relation to same-sex couples going through IVF. One who's wanting to carry their partner's egg now and use their eggs later in their low 30s, but they do have a low AMH of 1.6, and wondering how this might affect their IVF options and if a successful pregnancy is still possible.
Yes, certainly successful pregnancy is possible, but AMH of 1.6 is very critically low. So essentially, that indicates we need to get eggs fairly soon. So essentially what happens is egg reserve declines slowly. So it's been declining for a while. So now it's coming very close to zero. So which means once you go through this line, zero, AMH of zero, then you can navigate it back. So, and then you have a window. So window can be like 1 year, 2 year, because tail end is very low, so very slow. That during that period, you need to get sufficient amount of eggs. Embryos can be created using donor sperm immediately, or egg can be stored frozen. Then you can create embryos using donor sperm. But immediate creation of embryo is more effective treatment. So yeah, so here the urgency is to get eggs, good number of eggs before you run out of egg reserve. So yeah, so I strongly recommend starting egg freezing or IVF journey as early as you can. But the good news is because of your age, most eggs you produce are healthy. Here again, you can compensate for quantity of the eggs by quality. So, and most eggs you produce will be healthy, and but still need to go through the cycles and to create good amount of eggs and embryos to give yourself with your partner good chance of having a child.
And I would encourage that person who asked the question to call the team, because they have really great nurses to talk through processes as well. Okay, the final question before we kick off to part 2, and then we do have the questions at the end, is one that we often hear. Someone's asking, can IVF treatment flare up the symptoms of endometriosis and adenomyosis? That's the question, part 1. And is there any evidence for IVF actually increasing the rate at which the endometriosis grows?
Yeah, this very good question. What happens is if you do not have actually direct scientific evidence, we go back to biological plausibility. Let us say to get the direct scientific evidence on adenomyosis or endometriosis, essentially we need to observe like thousands of patients before and after. So let us say for endometriosis is more difficult. Let us say, for example, you need to do laparoscopy before and after without treating, and to see if it makes worse. So which is of course impossible. So all you can do in the future, maybe when new markers like imaging, where you don't do laparoscopy, you see in picture lighting up all these endometriotic nodules. They can do imaging before and after. In future, probably we will know more. But at this stage, there's no direct evidence that endometriosis is getting worse because of IVF. Essentially, now we fall back to biological plausibility. So essentially what happens, as you know, in endometriosis, this endometriotic cells are seated outside the uterus. So, and already cells are there. So when you have natural cycle, when you're ovulating, your estradiol goes up. Generally in natural cycle, natural ovulation, the average estradiol level is about 1,000 units estradiol. So that's more than enough for those endometriosis to lighten up, to get activated. So once estradiol drops, then after ovulation, progesterone increases, which means it prepares them to get discharge for the discharge secretory phase. So then progesterone drops, then you have a discharge of that endometriotic fluid into wherever the nodule is. So this keeps happening every month, whether you do IVF or not. So in IVF, essentially, you do not create new cells. Essentially, your endometriosis get activated during stimulation because the estradiol goes up, as normally it would, then gets deactivated, you have a discharge. So level of estradiol, of course, in IVF higher. Instead of producing one follicle egg, you produce multiple. Estradiol in average can be 5,000, 6,000, up to 10,000, maybe 5, 6 times, 10 times more. So when this cycle happens once, we believe same cells get activated, then deactivated. So there is something called threshold level for estradiol. Of course, estradiol is a driver of the activation of endometriosis every month. So that threshold, if it's set to 1,000 units of estradiol, which is natural level, so you can have estradiol of 3,000, doesn't matter. It's already activated. It's going through the threshold. We think it's the same for adenomyosis. So we see patients who we treated hundreds of patients with adenomyosis. We have got very good data on adenomyosis. So we see them from the beginning. Some patients need multiple cycles, many months of treatment. Generally, we observe them on the scan. We do not see this getting worse because these processes for endometriosis and adenomyosis is very slow. It happens across many, many years. When you become aware that there is adenomyosis or there is endometriosis, that's already like it was subclinical, which means it was there, but you were not aware. You might have had some symptoms, some pain. Even you do laparoscopy, the doctors say you don't have an endometriosis, but that's maybe subclinical started, not visible on the scan or laparoscopy or even MRI, but it is just it's gone. You just start seeing the tip of the iceberg once it is like revealed. But the process started many, many years ago. So because the process is so slow, just doing IVF itself doesn't, of course, totally we know doesn't cause, because its cells should be there before it gets activated, and we don't think it makes worse generally. But in future we'll know more after more research studies.
Yeah, there is so much to do, and as I have been saying, we are in a space where breast cancer was 20 to 30 years ago, and endometriosis has so far to come. But in terms of research, we are starting to see some runs on the board, and because you all keep showing up and doing all your bits of the pieces of the puzzle, it means we can keep pushing to make sure that we do have the right care and support and research so that everything that we are promoting or talking about is evidence-based. Awesome. We will get started and kicked off into part 2 now, and please keep the questions coming through. We are tracking them on a document. So when you pop them into the Q&A or the chat, we're pulling them over and pulling them into a document. So we're capturing them. And if we can't get anything through tonight, we will work through those responses and circulate it as a post-webinar paper as well, document as well. So over to you, Dr. Rusty, for part 2.
Thank you. Thanks, Jess. Thanks, everyone. So yeah, so like we do in real clinical consultation, now we move to the practical steps. So first we build a big picture with a couple together, understand why they had infertility and what we can do to overcome if they need IVF, for example. Then we agree, okay, this is a decision. So then after that, we move to the practical steps. We understood now we have a goal, which is achieving successful pregnancy or preserving fertility for future. Then next step is practical steps. And now I explain to my patients how we achieve that, what actually logistical, practical steps we need to undertake. That's not less important, because to have a smooth cycle, we need to have a full understanding of the cycle. So essentially, then I explain how we do IVF. So essentially, IVF consists of 7 stages. They are separate stages. It is easier if you understand each stage independently, and of course they're linked to each other. So, and then as you go through IVF, you can monitor, actually, you know which stage you are in now and how it is going. So when we analyze IVF, also we analyze in 7 different stages. We actually look, oh, this part went very well, or this part didn't go well. Why? Is it because of egg maturation or sperm quality? So this is why we need to break it down into small parts. It's very complex otherwise. Even to understand complex, if you break it down into multiple parts and tackle one by one sequentially, it becomes easier. So first stage of IVF is a baseline workup, which is a preparation if before starting IVF. Second stage of IVF is ovarian stimulation. That's stimulation of ovaries to grow follicles and grow egg inside the follicles and takes them through final maturation. And third stage is a collection of eggs and production of sperm, then fertilization of those eggs, then embryo development, then transfer of embryo or freezing of embryos, then supporting the pregnancy. If you had embryo transfer, then supporting that pregnancy with the progesterone. So baseline workup is one of the critical steps of IVF. So it starts from seeing your GP. GP runs all necessary tests that tests to assess your general health, tests to assess your egg reserve, AMH and antifollicle count, pelvic ultrasound scan, your partner's sperm, then requirements for IVF, tests which is required for IVF, that's screening tests like chlamydia, gonorrhea, HIV, hepatitis, all these infections, and plus your immunity to rubella, varicella. So all this in genetic carrier screening. These are the tests generally run by GP. And then if they're abnormal, then you can discuss with your fertility specialist. So this is a baseline workup. But most importantly, in the baseline workup, you create individualized protocol for yourself. So for each couple, for example, in Adora, we do not use standard protocol. For each couple, on the basis of what factors they have, we create individualized protocol. So individualized protocol consists of plans for ovarian stimulation, which means what drug you should use for stimulation, which is FSH drug, and what dose you should use. That's determined by egg reserve and age, and what trigger you should use. So then also for fertilization, whether you should fertilize with ICSI or IVF. So your specialist creates individualized plan and documents that individualized plan, and they explain to you, and everyone follows that plan. So this why, because of cycle planning so critical to achieve successful pregnancy. So that's the baseline workup stage is very important, and also the discussion of your factors like embryo and uterus factors is included in that baseline workup. So after seeing your specialist, uh, uh, what happens next is you speak to nurses. The nurses will send you a full pack which contains all the information you need in written format or video information. You just watch the videos which explains everything about IVF cycle, how you do the injections, and you get forms for the blood tests and prescriptions. So then once you've spoken to the nurses, generally you're ready to go. So then it's generally up to patients when they want to start IVF. They can start IVF with any menstrual period. Then we wait for the couple to make a decision when they would like to start IVF, and then ask them to do blood tests at the beginning of menstrual period to start IVF. So then you do blood tests and then inform the nurses saying my period started, I've done my blood test, I'm ready to go. So then you receive instruction which contains what drugs you should use and when you should start the drug, dose of the drug, then when you should do your first ultrasound scan and blood test. So then as soon as you start injection, you move to second stage. That's called ovarian stimulation. So any given time, ovaries contain number of antral follicles. So it really depends on egg reserve. Let us say if your egg reserve is AMH in antral follicle count is approximately 15 to 20, in average you have 15, 20 tiny follicles which contains egg inside. Each contains egg. So what happens is you keep bubbling up new antral follicles every day and keep losing old ones every day. This is an ongoing process. You cannot stop. So depending on how many antral follicles you have, how many antral follicles you have and their size on the day one is one of the biggest factors determines how many eggs you get and the maturation of those eggs. Of course, there are other factors like what drug you are using for stimulation, the dose of the stimulation, how long you're doing the stimulation, and monitoring whether trigger was optimal. So there's a number of factors, but number of follicles you have in ovaries and their size at the time of starting is important. So antral follicle means any follicle you have in your ovaries which is less than 1 centimeter. So these follicles are ready to go, but they need a hormone to stimulate them to grow to bigger size. So essentially, you start daily injection of stimulation drugs. This is one of these drugs like Gonale, Purigon, Ricavel, Menopur. These are all FSH drugs. So these drugs are generally copies of your own natural FSH hormone you produce every day yourself, but in higher dose. Your natural hormone essentially enough for 1 follicle, maybe 2. So here we want to get approximately 10, 15 eggs if we can. So this is why they're in higher dose. So when you do these injections at home for 8 to 10 days, 12 days, depending on how you're responding, the follicles which measure 2 millimeter to 10 millimeter, they grow to 12, 13 to 20 millimeters. So we want to get as many follicles safely, not too many, because if it's too many, then there will be higher risk of ovarian hyperstimulation syndrome. So into maturation stage. So that's approximately 14 to 21, 22 millimeter size. So they are in different size. They grow in different rate, but we want to capture as many mature eggs as we can. If you don't capture right time, they over mature. If they capture too early, they will be immature. So this phase of ovarian stimulation in average lasts 10 days. And some patients respond very quickly and they will be ready for the trigger within 8 days. Others need maybe even 15, 18, 20 days. So this part needs to be individualized, which means if patient needs longer stimulation, we need to keep going, keep doing repeated scans and blood tests to monitor until we see a lot of good sized follicles. So yes, so essentially this first phase is ovarian stimulation using gonadotrophin. Gonadotrophin means FSH. So what happens is after 5-6 days of stimulation, when you are growing a lot of follicles, your estradiol is going up, your pituitary gland, your body will feel that actually now time to ovulate those growing follicles. If you do not block the pituitary with the drugs, you may have a premature ovulation before even reaching egg collection. This is why we need to add a drug, antagonist drug from day 4, day 5, depending on duration of your menstrual cycle. So that's generally ganirelix or cetrorelix, one of these drugs. So then you initially started stimulation drug, FSH. So then on day 4, day 5, you add second drug, ganirelix, to stop the ovulation, and you keep going with daily injections. So then you start monitoring of the cycle by doing blood test and ultrasound scan. On blood test, you want to see how much of estradiol you're producing, because only source for estradiol is growing follicles which contain egg. Higher the estradiol, the higher the response, which means you're producing a lot of follicles with a lot of estradiol. If estradiol levels are low, actually response is going quite slow. So, and also you check other hormones like LH, which is ovulation hormone you naturally produce. We want that LH level to be low to ensure that your ovulation is not going to happen. Then we check progesterone. Progesterone is a sign that you may have ovulated if it's very high, or your follicles producing a lot of progesterone even before ovulation. So these things we monitor in blood test forms, blood tests with blood tests. And then we do ultrasound scan. The ultrasound scan, we count how many follicles growing in each ovary and size of those follicles. This is one thing. And the second, we also check the uterus. If the lining is growing fine, if there's any fluid inside the uterine lining, if there was any polyp which was not detected previously, fibroid. So we are checking, especially if you're planning to do fresh transfer, we need to ensure that uterus is optimal for implantation. Endometrial thickness should be more than 7 millimeters in average. So these things we monitor. Then essentially the second stage takes approximately 10 days, involves a couple of visits for blood tests and ultrasound scans. Then after usually second scan in most patients, you'll be ready for the trigger shot for maturation or ripening of the eggs. Eggs grow like fruit. Initially, they are small follicles. They need to get big first, then need to ripen. So to grow them, you do daily FSH injections, gonadotropin, menopur, all these injections. And for ripening, you need to give LH injection. So both of these hormones you naturally produce, but here we are using in high doses. So normally after second scan and blood test, we see lots of follicles ready to trigger shot for maturation trigger. Then you give a maturation trigger. Normally it's night time, evening time, because after 36 hours, when it's morning, after 2 days for the clinic, the follicles should be ready for aspiration, for egg collection. So you get very clear instructions saying you use this drug. Usually it is Ovidrel. The other one is called Coriamon, or you can use the decapeptyl. There's 3 different triggers we use generally. So you do the trigger shot, you receive a text message and phone call from the nurses saying, this is a medication, you need to use your FSH and antagonist this time and trigger this time. Then they give you instruction for fasting for egg collection. So then you do the trigger. Next day you do nothing, wait, and the day after you come, which is approximately 36 and a half hours after, you come for egg collection. So at Adora, we do egg collection under full anesthetic. So, and now we're moving to the next stage, egg collection. So that day your partner provides sperm, unless you have frozen sperm. So, and for sperm production, also we need to optimize. Essentially, the testis contains two different chambers, one chamber for production, second chamber for storage. So, if a partner is not doing frequent ejaculation, there may be a lot of old sperm stored in storage unit we call epididymis. So this is why for partners, if they're giving fresh sperm, it is important to do frequent ejaculation from first day of starting injections until the trigger shot. So every other day or so to get rid of old stored sperm so that on the day we get fresh sperm. Then they abstain from normally from the trigger day, then provide sperm on the day of egg collection, unless already we have frozen sperm. So then egg collection day, you will be greeted by admission team, and they go through everything and make sure that you fasted, and then you see fertility specialists. They get consent, and they double check your trigger time. If you have questions, they can answer. Then you speak to anesthetist. They go through all your medical history and make sure that they haven't missed anything about your medical history. Before that, they already get questionnaire. They know your medical history, but they double check. So they again check your fasting time. Fasting should be 6 hours, no fluid, no food before egg collection. So some anesthetists allow only clear water until maybe 4 hours before, but generally it is safe not to have any food for 6 hours. For patients who are in the GLP-1 drugs like Ozempic, Wegovy, different type of drugs, each clinic has got their own rules. In our clinic, they need to fast 24 hours before egg collection. They can stay on those medications provided they're not planning to do embryo transfer. For embryo transfer for pregnancy, we need to stop GLP drugs, Wegovy, Ozempic, all these drugs, at least for 2 months. But if you're just doing banking of embryos, you can stay on those medications, but fast for 24 hours. So then you see embryologists. They go through everything. They explain how they're going to do fertilization, whether they're going to use IVF or ICSI. Generally, if sperm parameters poor, we do ICSI. If sperm parameters good, we do IVF. So they explain the processes in the lab, how they do fertilization, how they check the fertilization, when you will get phone call from them, which will explain how many of those eggs fertilize, and when do we do the transfer. So they explain everything what happens in the lab. Then you will be ready to have egg collection procedure. At Adora, we do egg collection under full anesthetic. So it's like deep sedation. So it's like very similar to general anesthetic. So you go to the theater, and again, we do double check, triple check of names and address and everything. So generally, not generally, actually, it is very safe in terms of your eggs and sperm in the lab, and theater is very safe, because when you go into the lab, before you go into the lab, there will not be any medical records of any patient. So only your records will be there. There won't be any like dishes or anything containing anyone's eggs or anything like that. So when you go, and then we start chain of checks. So every step when we are handling eggs or sperm, it needs to be witnessed and checked with the patient. And whenever you be manipulate egg or sperm, at least 2 people should witness and keep signing. This is why in IVF, we keep repeatedly asking same question. What's your name? What's your date of birth? What's your address? What's your partner's name and date of birth? This is at the time 2 people are listening and checking all the time. The same thing happens in the lab. Every step we keep just with each other, we keep checking. So this thing happens. So you have we check your ID, we check the dish where we are going to collect the eggs to make sure it belongs to you. So, and after the checks are done, then you have an IV line, and then you have anesthetic. It's like propofol anesthetic. I think it's the best anesthetic for egg collection, because here in propofol, you have a deep sleep. You don't recall the procedure, and you will be actually asleep, and you do not have any pain. Equally, you wake up very quickly. It's not like full general anesthetic where recovery is so difficult. So deep sleep for half an hour, So actual procedure lasts about 10-15 minutes because it's very simple. I will explain. So then after half an hour, you wake up and then move to recovery. And after a couple of hours, you go home. So actual procedure is very simple. We do internal scan, same scan as you normally have. Only difference, we attach a needle to the scan probe when you're asleep. We just puncture the one side and they go into the right side. And generally with one puncture, we get all the follicles. And the second puncture on the left side, and get all the follicles of the from the left ovary. Essentially, distance between your needle and the ovary is only 2-3 millimeters. Because when you stimulate the ovaries become big, very visible, just sit next to the vaginal wall. So we do aspiration of eggs, and each sample will be passed to the scientists. They look at the microscope and count the number of eggs and send all the fluid again to the lab. They look at the bigger microscope in case some of these eggs were not visible in the theater, and we tell how many eggs you got. Then if it's ICSI, same day your eggs will be fertilized with a partner's sperm. If it's IVF, all eggs will be left with a partner's sperm overnight for fertilization. So for sperm selection, we use microfluidics for all patients at Adora. That's a very superior. In the past, we worried a lot about sperm DNA fragmentation, but here, when you use a microfluidics channel, it eliminates all unhealthy sperm. And after going through microfluidics, all sperm DNA fragmented sperm get eliminated. So this is why we don't need to even check for that, because this is such a good sperm selection method we use for all patients. So then for whether it's IVF or ICSI, we use sperm selected sperm and put a large concentration of sperm with each egg if it's IVF. If it's ICSI, we inject each sperm into each egg. Let us say if you've got 15 eggs, mature eggs, you find 15 healthy looking sperm, then inject one into each egg. So then next day, we check fertilization. So you get phone call from the nurses, phone call from the lab. They tell you how many eggs you had, how many of those eggs were mature, and how many fertilized. So approximately 70-80% eggs you get should be mature, and 70-80% of mature eggs should get fertilized. That's normal. If it's high, that's excellent. If it's lower than that, when we analyze, we try and understand why it was lower than expected. So then we keep the embryos in the incubator for 5 days. In Adora, we do single stage incubation. That's best because you shouldn't really disturb embryos too much, because during those 5 days, and naturally these embryos in the fallopian tube, which is dark and warm, and there's no light. So you should try and mimic that environment. So after 5 days, we open the incubator and check how many of those embryos develop to become high grade. So essentially, we categorize on day 5 whether we are transferring one or freezing all into 3 different categories: top grades, borderline, or we call average grades, or poor grade embryos. Poor grade embryo means they already degenerated or they stopped from developing 2 to 3 days ago, and they don't have any chance to implant, and they are discarded. High grade embryo means grade 1 or 2A or B grade embryo for both baby and placental cells. Average grade embryos, generally baby cells high grade, placental implantation cells are low grade, grade 3. So anything with C or grade 3 in assessment is an average grade embryo. Top grade embryos only have an A or B or 1 or 2 markings. So the difference is high grade embryos give you higher chance, at least 2 times higher chance than average grade embryos. So then if you're transferring one, you start progesterone 3 days before embryo transfer, nurses will explain, then you do embryo transfer. Then remaining high grade and average grade embryos get frozen on day 5, and embryos kept another day, given more chance to improve themselves, repair themselves. Embryos can repair themselves. The abnormal cells can stop developing, healthy cells can keep dividing. Then the average grade embryo or embryo which is growing slower, next day may become good grade embryo. If they do, then we freeze on day 6 remaining embryos. Then you stay on progesterone, and after 10 days after transfer, generally, you do pregnancy test. hopefully it is positive. If it is, then we repeat again after 48 hours. If HCG is growing, doubling, progesterone is more than 30, then you continue progesterone and do scan after you do 7 week scan. It's approximately 3 weeks after. So 4 weeks after. So then the whole cycle is finished. If you're not doing transfer, if implantation didn't happen, then you have a review consultation by a specialist, and they review everything and explain everything about the cycle and analyzing stage by stage, understand why we had such a good outcome, unexpectedly good outcome. It happens all the time. That's excellent. Because when we estimate, we give you averages. You may actually, your egg quality or partners from quality maybe much better than average in terms of quality. Or if you have a poor outcome, we try and understand why is that. Is it sperm? Is it egg or egg maturation or response? Then you optimize by changing the drugs and if necessary in addressing lifestyle factors, health factors, and optimize and go again to create new embryos. So the whole thing from first day of the menstrual period till embryo transfer or freezing takes about 17, 18, 19 days. After 10 days, you find out if whether the cycle is successful. So it takes approximately 28 days. It's exactly the same as natural cycle. So this is a duration. And generally, it involves 4 visits, 2 visits for blood test and scan, 1 visit for egg collection, and 1 visit for embryo transfer. If you're not transferring, if you're just banking, 3 visits. So these 2 visits, essentially IVF, you can do everything as normal. You don't need to take time off. If you have to, you can. But this one day, on day of egg collection, you cannot work. You need to take full time off. You need to have someone with you because you have anesthetic. Someone needs to observe you 24 hours during that period. So that is a whole cycle of IVF. Generally, it's very streamlined. Generally, all should go smooth, and you have a direct line to nurses and admin, and you can discuss with your specialists. So we generally your specialists, so nurses will guide you through. So you don't need to organize anything like bloods and scan. You just follow the instruction and just keep following the nurse instruction. So this is an overall IVF cycle. That's practical steps of IVF.
Thank you so much. Oh my gosh. I don't know about the people in the chat. I'm open to answering any comments or around, but it's so good to just have it actually broken down like that because it can be so overwhelming. And I feel, or I've heard for many years, it's just this big cloud of IVF or I'm going through IVF, but to actually understand, break it down, the different levels, elements, and having partners understand this too, or, you know, communicating this to colleagues or workplaces. When someone says they're going through IVF, it's often just oh, okay, all right. But there's so much going on in someone's body, but also their mental load, navigating this as well. And yeah, this is why you really do need that team around you and some kindness and some care. Thank you again for just stepping it out. I think it's really great information and welcome. People are really welcome to make comments in the chat as well. I'm just going to pull up those questions that are coming through since you've been speaking. One of the questions is, how does a vasectomy affect sperm collection?
Yes, a very good question. So essentially in vasectomy, of course, production is happening as normal. So here the sperm's role is to pass the DNA, paternal DNA to the egg. So this is the only pretty much only job of the sperm. So provided DNA is healthy, intact, and passed successfully, the job is done. So in vasectomy, and because there's no infertility, male infertility, the production is happening as normal. Just it's not getting out in the ejaculate. So the best, of course, there are 2 options. One is a reversal of vasectomy. In the past, when IVF was not accessible, so that was main method. But generally, IVF is much better option. TISA plus IVF is a better option because less stressful and more successful. Let us say if you do reversal, so 50% reversal actually may be successful, then still there will be reblockage of the higher chance of getting the blockage of the duct as well. So, and also sperm param quality will not be as good. Maybe if it was normal before, it may be lower in motility and concentration. Still may be harder to get pregnant naturally. And the third is the high chance of developing anti-sperm antibody. What happens is when sperm is developing, sperm has got its own DNA and it is foreign to body. And the sperm is protected from the body immune system with a sperm blood barrier. It should not cross a tissue, blood cells. If it does, immediately immune system recognizes as a foreign body and starts producing antibody against sperm. In a lot of patients with vasectomy, they develop anti-sperm antibody because sperm starts leaking and they develop antibody, which means the sperm cannot successfully bind to the egg to fertilize. So yes, a lot of patients can have success if they have partner have reversal, but if you compare to IVF success, it's less successful, more challenging, maybe even more costly than having reversal. Simplest option is doing TISA. So in TISA, so there are two different sperm extraction methods. If abbreviation ends with A, so which is aspiration, which means cut, we don't need to do any cut, we just aspirate with a needle. Is TZ, which is an abbreviation, ends with E, which means extraction, which means open procedure. So vasectomy patients do not need open procedure. They just need aspiration with a needle. So they can have a procedure same day. So when partner is doing egg collection, the male partner can have a TISA, which is very simple procedure. Again, at Adora, we do under full anesthetic, like in egg collection. You use a syringe needle and aspirate sperm directly. And usually you get sufficient amount, like 4, 5, 6 straws of sperm to freeze, and you have sufficient amount to fertilize. So if first cycle is not successful, generally partners do not need repeat procedure. You can just store one straw and fertilize. So TISA in vasectomy is the best solution. So and because sperm DNA is healthy, because there's no infertility, and the chance of success is as good as ejaculated sperm patients. So because once you inject the sperm with ICSI, then the rest goes as normal because there's no issue with the DNA of the sperm generally.
Interesting. Okay, so we've got a couple of comments. So just a comment, that someone wish they knew all of this before starting IVF, not learning while they were in it. So that was that's good. I'm glad it's been helpful. And another comment, someone has said it's so useful seeing it all mapped out like this. I couldn't agree more. On the point that you've just said, Dr. Rusty, about being under general anesthetic, why does Adora choose to put their patients under general anesthetic?
Yes, so essentially, I worked in UK. I worked in different IVF clinics in UK, Manchester, Cambridge, and Aberdeen, and different settings. And one of these clinics, we did a collection on without anesthetic, so with those alarm and local anesthetic. And I certainly prefer full propofol anesthetic. First, patients are very relaxed. Of course, they don't have a pain. And the second is we take our time to aspirate every single follicle. Some patients can produce lots of follicles, let's say 15, 20 follicles, and we aspirate and we tend to get more eggs because we're not leaving even small follicle behind. So there essentially a collection, there are two methods. One method is you just go after big follicles only, assuming small ones do not have a mature eggs. Second method is you collect everything, which we do at Adora. So when patients are under anesthetic, we aspirate all follicles because after sending the fluid, some smaller follicles may give a mature egg. So we can't tell by looking at the size. Only lab can tell under microscope. So scientists can tell under microscope. So yes, this is another reason. So just take our time. We aspirate all follicles. Patient is fairly comfortable and they don't have pain. So yeah, when I compare my previous experience at Aberdeen in Scotland and here, I'd certainly prefer doing procedure under full anesthetic.
So if a couple's going in for sperm retrieval and egg retrieval, we'll need lots more drivers to get them home. Absolutely.
Yes.
What if someone has this is a I'm assuming based on I guess a normal cycle, this process. What if someone has a shorter cycle? What does it look like then?
Yes, so so essentially the two, three things determine how each person responds. So one is we give it a drug. So then in the surface of follicle, inside the ovary, we got follicle. On the surface of follicle, we have got two different receptors, like sensors. So for one is for FSH drug, and second one is trigger drug. So these are copies of natural FSH and natural LH. So that response depends on how the sensors are working. It's one of the reasons for fast response. So in some patients, you just do a scan after 8 days, they already have a lot of large follicles. You can't go any longer. If you go longer, they start getting over matured eggs. So they immediately respond. They always respond fast, generally. So in this case, you do stimulation, you do scan after like not seven, it is a little bit too early. Generally, on day eight, you already have a good response. They may just need one scan, then trigger and get a lot of mature eggs. Some patients, you need the receptors do not fully register that one part type of FSH, for example. If this happens, they have a very slow response. Then you keep going and get eggs. If they need more IVF, if they didn't get good result, then you need to change the drug and try and find right drug which match their receptors. So yeah, so but average is average 10 days. Most patients need approximately 10 days to respond.
We're coming to the end of time, and I'll just leave with two more questions, and then we'll take all of the questions onto offline and work through them and put them out to those that are to everyone's email addresses as well. So one of the questions is in relation to ovarian hyperstimulation syndrome, wondering if someone with a history of PCOS, endo, and adeno, the trifecta, AMH levels were tested 2 years ago at 85.11. Wondering if they're in danger of ovarian hyperstimulation syndrome if they do undergo IVF or an embryo freezing, and are there other medications for or options during the cycles?
Yes, I briefly explain about the risks for general population. So essentially, risk of having ovarian hyperstimulation syndrome, which requires hospital admission, is 1 in 200, which means if you do 1,000 IVF, 5 patients need to go to hospital for observation for a few days. So that's not very common. So essentially, in the ovarian hyperstimulation, determined by a number of factors. One factor, of course, is PCOS. Having PCOS increases risk. Second factor is the drugs, like dose of the drugs and trigger drug. So, and the third factor is individual variation. So, the genes determine who gets PCOS, and there's some rare genes which increase risk of ovarian, but they are rare. This kind of genes may be so rare, it may happen in 1 in 5,000 IVF cycles or 10,000. So these are rare. And generally, in terms of reducing risk, we can, in some patients, like if they have a reagent, we may not be able to prevent, but generally there's a lot of things we can do to reduce the risk. Let us say we start with low patients with PCOS, we start with low dose of stimulation, careful monitoring, and trigger with a decapeptyl and freezing of embryos. So shortening of stimulation. Let us say if we are deciding whether we should go a little longer and get more eggs or trigger earlier, if you have still good number of mature eggs earlier, maybe get less eggs and reduce the risk. So there's a lot of things we can do to reduce and minimize the risk of ovarian hyperstimulation. We have quite a lot of control over stimulation, but we do not have a full control. If you use the same drug for patients with the same age, same AMH, we may have entirely two different results. So when we are seeing that some patient, if patients respond being high, then we start mitigating the risks by maybe lowering the dose or stopping FSH drug, doing early trigger or using decapeptyl trigger. So we keep working on risk reduction. So, but in the big picture, having severe ovarian hyperstimulation is not common. So like 5 out of approximately 1,000 women undergoing IVF will need to go to hospital for observation and pain relief and IV fluids if they have OHSS.
I spoke to a woman today who had 4 episodes of ovarian hyperstimulation syndrome through her cycle, and she still eventually had a beautiful little bubba. And I think her bubba would be over 20 years old now. So medicine comes a long way, and that someone so unlucky still had a beautiful ending, a beautiful story. So that was a nice outcome for something so horrible. As we wrap up, I just want to, there's a lot of comments or questions about, is there hope for someone that does have that trifecta of endo, adeno, stage 4 PCOS? What would you tell them as, the leaving thoughts, Dr. Rusty? Is there any hope for them to conceive and to be successful?
Yeah, absolutely, absolutely. Actually, here the same thing. Like PCOS, in a way, good thing to have. In a way, good thing to have because there's no shortage of eggs. So we really have a problem when you have these factors like adenomyosis, endometriosis, but we cannot get sufficient amount of eggs to create high-grade embryos. But PCOS, it's not a problem. Yes, of course, we need to minimize risk of ovarian hyperstimulation syndrome. So here, generally, you use your advantage, which is egg quantity, to create embryos and compensate for these advantages, which is endometriosis and adenomyosis. Yes, very, very likely, very high chance of success. So in IVF. So yes, PCOS, we are a little careful because of ovarian hyperstimulation syndrome. We need to try and mitigate as much as possible. Actually, PCOS patients are good prognosis patients, despite having other factors like adenomyosis and endometriosis.
Mm. I'm sure people that are living with PCOS have never heard a doctor say it's a good thing that's a positive. So yes,
They're my
look,
favorite patient.
yeah, absolutely. And honestly, from my experience for the last 12 years, again, I've spoken to thousands and thousands of people with endoadeno, just the most horrific disease through their body, and they have successfully conceived naturally or successful IVF cycles, but it is a hard journey. And we thank you for the education and the mapping out, Dr. Rusty, and also the service. I think, Adora, you guys have a really good service down there in terms of what you're delivering. And I was really surprised and impressed with that a couple of years ago when I connected with you. So the quality is there. It's at the level of other clinics, which is again a concern that we would always have, or others have shared with us. So yeah, thanks for offering such a accessible service to people. It's really important. Ash, we're wrapping up now. Were there any final comments or any bits of admin that I've forgotten?
No, just to let everyone know that if you're wanting to watch this back later on or share it with someone who might be thinking about IVF or really wants to watch it back with their partner, in a few weeks' time, this will be available online on our Manage Endo platform. So don't think that it's over, it's done, it's not accessible. We will have this ready on Manage Endo in a couple of weeks for you.
Yes, thank you. Thanks for inviting Jess, Ash. Thanks for everyone attending. So you dedicating your valuable time in the evening after work and your daily activities. Yes. So in terms of books, I'm more than happy to share the adenomyosis book, which I sent. Did you receive by email? I sent, yeah. So we can share with all participants. So egg freezing book is in press, so it will get published physically within 4 to 6 weeks, and I will send a hard copy for each participant. And the IVF book hopefully gets published within 2 to 3 months, and I will send a copy of a hard copy of these books. Yeah, no, thanks everyone. Thanks for organizing today's webinar, and thanks for everyone attending.
Absolutely. Great. Well, thanks again. A big thanks to all of us, to you, Dr. Rusty, and for giving up your time and sharing. And this education piece is so valuable, and people knowing and going in with education, armed with knowledge, and also I think some questions that they can also ask helps them to really be involved and confident along the journey. Have a great evening, everyone, and we will chat with you soon.
Thank you.
Bye.
Thank you. Thank you. Bye-bye. Bye.